morning, everybody. I can already see there are 60 people online. We'll not get into the details as to what went wrong. So we are good to go. And thank you for being with us for this, what we are now trying to call the Friday 8 p.m. sessions. We hope to make this a regular event for coming for every Friday. And I will take you through, as I said, the enhanced recovery after surgery, the anesthetic management. And what I will try and take you through is try and get you a kind of a template as to what you can use, especially for students when you are trying to get in for, you face any question that you get as to anesthetic management of a patient undergoing X surgery, Y procedure, or D operation. So I think this serves as a very good template. So what essentially is this ERAS? And ERAS has come as a question. It is asked during practicals. It is asked in theory. So what exactly is ERAS is nothing but enhanced recovery after surgery. Some people also call it the enhanced recovery pathways. And this came out with a publication from Kellett in 2008, which essentially is nothing but multimodal, multidisciplinary fast-track surgery. Right now, we kind of associate this with things which can fasten recovery after various type of surgical procedures. And these protocols that you have are evidence-based therapeutic interventions, and this starts in the preoperative period and goes on till the postoperative period. And you'll find a lot of these protocols and guidelines which come in, and these keep evolving. And so the last that I could go through were ones that were published in 2019. And a good friend of mine, Dr. Girish Joshi, sitting in Texas, has been one of the key proponents of these ERAS pathways. So what does ERAS or ERP try to do? It is they're trying to do a standardized care, and this standardized care can be taken over through all institutions, so that we then know, if you go get them through these protocol, that do you actually improve the outcomes. They take into account that the surgery is a huge kind of an insult to the patient's physiology. So there is a huge surgical stress response, there is post-operative pain, and if you can manage these two effectively, you can reduce complication and improve the outcomes, and which essentially leads to decreasing the hospital length of stay and expedite the recovery following a lot of elective procedures. So this is the ethos of ERAS. Is ERAS anything different than what we used to do 10 years back, 15 years back, 20 years back? It essentially is not. And this is what we keep telling people, that the principles of perioperative care for major surgical procedures, particularly the preoperative and intraoperative management, remains the same. It's only that few things have been brought into limelight. Some things have been highlighted. Some things have been figured out, that which was done routinely, kind of without much of evidence, is not been doing good to patients, and it's time to abandon that. And there are certain things that you do for certain procedures. So there are few procedure specific variations. What we will go through today is not very procedure specific, but a very generic one. This is how the ERAS, I think, I came out, I talked about in the early 90s that it came out, and they had a huge number of elements that were part of the protocol. Till it's around 2001, they figured out that not all of these are equally weighted, and there is not enough evidence to suggest that they improve post-operative recovery and decrease complications. So the ERAS elements, and these keep changing. And the one that I could find in 2018 were, I think, few of these that I have just put in, and we will go through this as we go through the evening. One is no mechanical bowel preparation. I know that as an anesthetist, we are not much involved with this, but it is one of the elements, in a huge element. I think we talked about myths about feeding and fasting, and this is what we learned from ERAS, that you allow a light meal up to 6 hours and consume clear fluids, including the much talked about oral carbohydrate drink until 2 hours prior to the initiation of anesthesia. Pre-medications, and this is, I think, a huge area that I have learned from ERAS after following ERAS, is that pre-medications is not the classic pre-medications that we learned in our residency days, but this pre-medications would be uh, pain medications, and classically the non-steroidal drugs, acetaminophen, NSAIDs prior to surgery, and possibly antiemetics that you start prior to surgery. Intraoperatively, maintenance of normothermia, euvolemia, which I think intuitively everybody does. Again, a huge surgical thing. Don't put in tubes and drains if you don't need to. So avoidance of surgical drains and nasogastric tubes. And this is a collaborative effort that you do along with your surgical team. Infiltration of the wound with local anesthetics. And I think as we have evolved over the last couple of decades, we figured out what is the best plane also to infiltrate this local anesthetics. We'll go through that. Huge focus has been on post-operative nausea, vomiting, because it's a huge indicator for recovery in the post-operative period, and the use of antiemetics. Early introduction of solid diet, and I think we had questions in the previous session on this. Multimodal narcotics pairing, and I think opiate has become a bad boy in the books of many. And so ERAS has tried to focus on sparing narcotics. IV fluids, try to get the patients off IV fluids as quickly as you can. If you can fit the gut, if they can tolerate feeds, something like 600 mils, lock the IV fluid, remove the drains, remove the catheters as early as you can, active mobilization. And back to what we can do is optimization of comorbid conditions pre-op. Huge focus on antibiotic prophylaxis. Most of you would do this intuitively. This is again coming into focus, venous thromboembolism prophylaxis, and this we realize that even the Indian population is very vulnerable and susceptible. We used to think that it happens only in the West. It does not. It happens to us as well. And lung protective ventilation. These elements are the ones that we'll go through over the next few moments. The stakeholders are just not the anesthetist. The patient is the primary focus, and it's also the surgical team which needs to be in. You have to involve your nursing staff, and essentially the institution has to be focused about ERAS to make it successful, because there are multiple facets from the pre-operative period, during the surgery, and in the post-operative, and unless everybody speaks the same language, you don't get to the desired effect. The journey, as I said, starts from the time the surgeon sees and decides that this patient needs surgery till the time they go home. We as anesthetists possibly are more focused at the intraoperative phase. So the preoperative considerations, I think this again is a no-brainer, that you optimize the patient's preoperative conditions, which can have a bearing on the postoperative outcomes. Coming to this again and again, minimizing the fasting period, maintaining the hydration during the fasting period. This is again is a huge game about communication, so this patient and family education and pre-medication. So comorbidities, not only do you look at the functional status, medical history review, medical reconciliation, what we learned from ERAS essentially is that we not only identify the cardiac and pulmonary risk, and this is, if you ask me personally, this is something that over the last 10, 15 years that I learned, that you look at the person's age, frailty, that this is the Gestalt law again. If the person looks frail, does not look good to you pre-op, be aware that may not do very well in the post-op. So keep this in mind. Things like, did they have history of falls? Again, this is related to functional status, but I think this is things that ERAS can has actually taught me. And we used to not take cognizance of the cognitive function of a patient. So figure out, are they kind of mentally alert and with you, and that will also kind of determine how well they would do after the surgery. So this is something that ERAS has focused on. I think this we have gone through. I will not take you again through this. And with what you're essentially trying to do is go from the fasted to the fed state. And why are you doing this is, I think, that you're reducing the post-operative insulin resistance and the post-operative weight loss. And so you're trying to keep them as fed up as you can. So pardon the pun on that. So I think Chimontika took you through this. You gave, some people have recommended, I would be a little skeptical to do this, but I would be happy with a glass of water, which is around 500 mils containing 50 grams of carbohydrate, but you can go up to that. And this is shown to have improved the glycemic control, but not necessarily about the infection control. I think this is important. PFE, this again, most people would do intuitively. You talk with the person, you talk with the person's friends, relatives, try to reduce the anxiety, tell them, get them on board as to what their expectations are, tell them about what your pain control management is going to be. If you're going to use something like a PCA pump, this is the right time to talk about it and get them on board. So if they are on board with you, I think the stuff becomes much, much easier. It's always good to have this kind of a new name to it. We have heard about rehabilitation, and ERAS gave me a new term called prehabilitation. And they came with this new prehabilitation program. So new is an acronym. N stands for nutritional supplementation. E is for exercise programs, and W is for worry and anxiety, which essentially is stress reduction. And you do this to improve the cognitive functions as well. And it also takes the prehabilitation, talks about smoking cessation. And why I tell this is a good template, so you can figure out that you can use this template to answer or to deal with any particular clinical scenario. Nutritional supplementation is again, it's because this surgically you develop this huge stress response. So you give them this load so that it mobilizes carbohydrate, lipid, and protein stores that are done during a surgical stress response is kind of optimized. And you are trying to do also work on is that to see that there is not a malnourished person who gets in. And people have figured out that there is evidence that a whey protein supplementation without exercise for colorectal surgeries, and you'll find a huge amount of data for ERAS procedures coming from colorectal surgeries, that it has decreased length of stay. This is a good algorithm to follow, and looks at the preoperative nutrition score. You look at things like the BMI. Is the BMI less than 20? I think is a good benchmark. Is there an unplanned weight loss which has happened in the last 6 months? And are these patients eating less? If the answer to them is yes, and if you find that the albumin level is less than 3, then it might be prudent to optimize this person's nutritional status before you take this up for an elective major surgery, especially major surgery. There would be people who would say that, do I have the time, especially if it is a major oncological procedure? I think if you look at the current data, waiting for 2 weeks to 4 weeks will not influence outcomes. And I think the COVID pandemic has also taught us this, that even in the so-called high acuity surgeries can be pushed to the intermediate acuity. So it might be prudent to improve the nutritional status.